that the world is now an interprofessional world. And so we've reorganized along the lines of people who have an interest in certain clusters. And that includes neurodevelopment, behavior, community and chronic community health, and lifespan. And as we've been reorganizing the Mailman Center, we're also trying to think about what impact are we having on the community. So for years we measure ourselves by the number of papers, the number of grants, the number of people trained. And we decided if we really thought we were having an impact on the community, we needed to start measuring how children and families are doing in our community and keeping track and saying, well, what are our goals? What are we really trying to accomplish? And then making sure that our work was all directed in that particular place. And just to give you a sample of one idea, we've been thinking a lot about how the Mailman Center is really well positioned to try to reduce health disparities among children with developmental disabilities and other minority status. There's sort of that intersection. And along those lines, we've chosen for our first of several grant rounds people who are deeply engaged in the community, understand what's happening there, have data about how our community is doing, and have strategic plans already in place about what we should be doing to help children and families. So it makes sense for us at Mailman Center to make sure that our goals and our strategic approach is aligned with what's happening in the community. So our first speakers are from the Children's Trust, and I think you all understand that Miami-Dade County is a pretty remarkable community in that it has decided to use tax money to try to support children and families. And this has happened over the last 10 years, really, largely under the leadership of Dave Lawrence. And the fact that we've done that is pretty incredible. Most other places are pulling back on children's services as we move forward. Our two speakers this morning, I'm going to quickly introduce them because I want them to get a chance to talk, and I'm hoping we have time at the end to discuss some of the ideas about where Mailman is headed and how it can help in the Children's Trust strategic plan. So I'll introduce them quickly, and then they will speak, and hopefully there will be time to have some conversation at the end. The first speaker is going to be Dr. Peter Gorski. Many of you know Dr. Gorski. He is trained as a pediatrician and as a developmental pediatrician. He's had faculty positions at Harvard and now currently at FIU and the University of Miami. He was the past president of the Society of Developmental Behavioral Pediatrics. He's very well known for his work with the Academy of Pediatrics and writing many of the guidelines for how pediatricians should interact with their community. And his current title is the Chief Development and Innovation Officer at the Children's Trust. Dr. Lori Hansen works very closely with Peter. She got her PhD in psychology at St. Louis University. She then did some of her postdoc training here at the Mailman Center and was on our faculty until 2003 when she moved to the Trust. Her current title there is Chief of Research, Evaluation Strategic Planning. I think many of you know Lori, and she's sort of the key person there for many of our collaborative work with the Trust. She's the person who really understands how things work, and we're really delighted to have both Peter and Lori here today. So please join me in welcoming them to the first Mailman Center Grand Rounds.
Hey. Thank you, everybody. Good morning. It's so nice to see you all and to be in this great new shining auditorium, the home of three of my personal friends and heroes, Dr. Brosco, Dr. Armstrong, and Dr. Schechter. I'm so honored to be with you, and I appreciate your getting up this early. I've always been a morning person myself. The only difference I've noticed as I get older is that I used to do my best thinking between 8 and 9 o'clock. Now I do all my thinking between 8 and 9 o'clock. We do have lots of ground to cover, and we'll get right to it. I'm thrilled that there's such a large audience for such a narrow topic as we've chosen, the state of the child. You're going to find that we range beyond the biology and physiology of early childhood health and development to incorporate what we've learned as science are some of the root causes and influences on positive and adverse outcomes. So I subtitled the talk, Race, Place, and Who's Your Daddy? The Biological Embedding of Stress and Support. And we'll see why in a minute. Thanks to Jeff for sharing this slide with me, but it illustrates really nicely how much the morbidity of childhood has changed. While there is still the good old triad of allergies, otitis, and asthma that afflict so many kids, for the most part, things have really flipped so that behavioral, developmental, mental health disorders occur in greater frequency than do the old microbial infectious disease causes. Now, this forebodes poorly on many levels for the ultimate health of our nation as an adult population. While the obesity rate is way too high among children, the impact on organ systems over time really wears us into pathological states depending on which organ our own bodies chooses to manifest. So the metabolic syndrome, still way too high at 7% among young adults, climbs to almost half the population by the time we're well into adulthood, predicting the epidemic rise of stress-related illnesses, chronic diseases like diabetes, heart disease, stroke, and cancer, and affects our overall life expectancy. And this point I raise only because the impact is differential depending on race, place, and who's your daddy. So that you could live 7 years longer in what it takes you to ride to work from home in most cities, big cities in the Western world. And I just learned this week that in St. Louis there's actually a 37-year life expectancy difference between neighboring communities. The one who's been in the news lately and the one who owns the newspapers that reports the news. It's not just an effect on our physical health, but on our capacity to relate and our capacity to work and to think. And the executive function of the central nervous system organizes as early in childhood as does the other neurological systems responsible for our health and development. Executive function, of course, determined or defined by inhibitory control, impulse control, working memory, and cognitive flexibility. You can start to see changes for the good or bad in executive functioning, even in young toddlers just out of infancy, through under-controlled behavior, low persistence, inattention, different processing of emotions, and by your ability at the age of 4 to resist a marshmallow placed in front of you for a few minutes. Predicting long-term outcomes like school performance, how much you're going to earn as a young adult, your vulnerability to substance abuse, your social class, and your physical health. So here we see why this is really critical, thank you very much, to the country, because it limits potentially the capacity to contribute to yourself and to others. In this nation, even as we climb out of the recession, still manufacturers are unable to find workers to be qualified to do the job. And our national security is threatened as 3/4 of all people who try to sign up for the military are rejected for one of those 3 reasons, actually in equal thirds. So overall, we recognize humbly as a medical profession that healthcare and biology combined account for the minority of the influence on human health and children's development. And that's because experience matters. And it matters especially early in life when our brain, central nervous system, and biological reactivity is developing. We know that, in fact, as we say, the old nature-nurture argument is finished, that perhaps experience not only reshapes nature and biology, but actually contributes more of the influence than our genes do by themselves. There's some very elegant research, this out of Montreal, switching out rat mothers, some who have been bred to nurture, others who have been bred not to neglect their rat pups, and then switching them up and finding that the foster mother changes the biological stress reactivity of the rat pup, and demonstrating that this is more a function of experience than of biology. So the experiences that seem to matter most are resources, material and human, relationships, and the internalization of those two influences into the child who must grow to feel proud, purposeful, and effective. Indeed, I can tell by looking at a 1-year-old for a few minutes what his or her likely health trajectory and developmental trajectory may be, thanks to how much they demonstrate that they feel like they have intrinsic worth, that they belong to something greater than themselves, and that they can affect change for the better for themselves and for others. They can make things happen. Any 1-year-old worth his salt will manifest that behaviorally. And the things that can erode that potential that is within each infant and young child are stressors, but not the old stressors, not, again, those microbial, the organisms that used to create pathology, but the new pathogens, the social pathogens listed on this page, among others, that run rampant, certainly in our own communities here in Miami. And again, depend, of course, on, unfortunately, more on where you live than on your biological substrate. And there's good psychophysiological rationale for the causal mechanism by which stressful experience gets embedded into our gene action system. When we don't feel good about ourselves, we stimulate a cascade of bad biochemistry that results in destroying brain receptors for stress-reactive peptides, other hormones that ultimately connect to and influence the physiology of our immune system and our cardiovascular stress reactivity. So the old way, we used to say it before we had the lexicon of early child and brain development, is that mental health is the root of physical health. The way we feel generates the mechanisms that cascade through our bodies. And the way we feel is largely a social construct, not simply an individual psychological or psychobiological construct. So we have to attend to the nature of society if individual health is going to improve and be protected. The UN Convention on the Rights of Children accurately captured, now a long time ago, but still yet to be ratified by this country, the notion that there are 54 essential needs and rights that every child must receive in order to thrive, and that no one is any more important than any other, and they are interdependent. So it's as important to be free from discrimination as it is to have shelter. Sadly, by the time we start to manifest symptoms, the mechanisms biologically are already set in motion to affect the life course. The ACE study that most of you must know from Kaiser Permanente, or certainly should refer to, demonstrates the direct relationship or association between adverse childhood events in the first 18 years of life, and these events are mostly events about parenting, about poverty, about social stressors that result in poor health 40 years later. Makes sense when you know that over the first couple of years, we're growing 700 new synapses a second, depending on the nature of the experience that we enjoy. So there are strong connections, always known, between children's health and adult health, between the wealth of a child's family and the wealth of the child when he or she grows into adulthood. Now we're appreciating that the economic security and social opportunity that presents to children directly affects their health when they become adults. And as a nation, we're not doing well by kids with respect to setting a healthy foundation for life, especially if you're African American or Hispanic. I'm shocked to know that half of all jobs pay less than $34,000 a year in this country, half of all jobs. That a quarter of all jobs pay less than the federal poverty level. So you can be working full-time and still qualify for poverty assistance. And only a small number of kids entitled actually receive such assistance. This is a big, big matter for those of you, especially who operate in the field of early childhood, because it turns out there is almost nothing that adds to the predictive validity of how a child performs in kindergarten that is going to predict to adult measures of health and of functioning. This is a national collaborative study called the STAR Project out of Harvard and 8 other universities around the country, or the landmark studies from Britain, Michael Marmot, one of my other heroes, and his co-investigators who demonstrated in the Whitehall study of 25 years of British civil servants, showing that social class is a greater predictor of death from heart disease than is your lipid profile. And it's not all about poverty, is it? Otherwise, why would it be that black CEOs, doctors, lawyers, PhDs have twice the infant mortality rate of white high school dropouts in this country? Or why is it that birth weight and prematurity rates in black Africans in Africa is the same as white Americans in America, but not of African Americans in the United States? So this is all about the cumulative balance over early childhood especially between supports and stresses that result in child outcomes. The last thing I want to mention for you to really think hard about is that we're all affected by these gross inequalities that become biologically embedded in children. None of us escapes. Even the most advantaged in unequal, inequitable nations and communities, and the United States and Great Britain are the 2 most inequitable nations in the developed world, suffer the consequences of unfair distribution of supports and resources during childhood. This is Wilkerson's data from a comparative study of England and Wales, the United Kingdom versus Sweden, 2 of the wealthiest economies in the world, but grossly different in terms of social and health policy and redistribution of means and resources across the population. And I only want to point out this first bar, the wealthiest and the Hollingshead categories, ranks. These are the richest, the most advantaged members of society, and you can see in Great Britain, the higher the bar in this case, by the way, the worse the health outcome. This happens to represent infant mortality, a pet subject for study of mine, but could have been any other health outcome or developmental outcome you choose. The most advantaged in Britain have poorer health than the least advantaged in Sweden. Stress affects us all. And there's good reason for that. Look at yourself and look around you. The more unequal our society or our community, the more aware we are of our social position. The faster we are to judge our social status within seconds of meeting people, the more we're likely to hook up with partners and colleagues who can do something for us rather than who we are attracted to in more lasting and deeply meaningful ways. And so the social health of our neighborhoods is the greatest predictor of outcome for our kids, above any biological index that we could choose. And so we have to operate on and with the neighborhoods who raise the kids and families that we care about and for. And we have to have residents join us in discovery and in treatment if we are ever to be successful. We have to recognize that it's not going to be good enough any longer to learn how to treat disease. It's not going to be enough to treat unhealthy behavior that leads to disease. We have to get to the root of toxic stress that leads to the unhealthy behaviors that causes the pathophysiology to change. And we have to work at the individual level and at the policy level. So I'm going to turn to my colleague, Dr. Hansen, who's going to review with you how, in fact, the Children's Trust is launching a new commitment to working at all of these levels in Miami-Dade County and to encourage your partnership with us. I'm going to take off all of these. I'm glad I didn't drool or pee in my pants because I would have died instantly from electric shock.
Angled here. Here? Good? Yeah. Okay. Good morning. Hopefully, some of you have seen the Children's Trust Strategic Plan. I did bring a few copies, but it's available on our website. And it was completed about a little over a year ago, an update. And it really emphasizes several things that Peter's been talking about already this morning. Our focus on the whole child and all of the aspects that relate to child development in terms of social support, educational, economic, environmental supports that are so important for success and growth for children. We also do focus on, as the Children's Trust, all children in Miami-Dade County, but recognizing that there's special attention needed for especially vulnerable groups. That includes children with disabilities, but also particular geographic areas in our community we know have greater needs, children who are in particular circumstances, perhaps with child welfare or the juvenile justice systems. So we do recognize that needs to be a balance between those. And the other big emphasis in our plan that Peter started to talk about as he wrapped was that partnership and collaboration is key. So no one entity, no single funder, no single stakeholder in the community can accomplish what's needed for children. Some of the weighty issues that Peter talked about require collaborative work together, require engagement of others to accomplish that work. And we do, a lot of what we do is we fund programs, but with doing that, we very much recognize children don't grow up in programs. They grow up in families and in communities. And so we also need to be supportive of those as we do our work. Because Jeff talked to us about what you guys are doing in terms of looking at your results and your measurements at the Mailman Center, I couldn't resist to share from results-based accountability some of the work that has really guided us at the Trust. How do we measure results? This is an important distinction to keep in mind when we're talking about results, that there's sort of two levels to look at, both equally important. but you need to keep the distinctions clear. So population level measures and indicators look at whole populations. This is where people will have to collaborate and work together to achieve results at the community level. At the program level, we all maybe operate in our own world of what we do. We have certain populations that are served, and we most certainly should be assuring that we're doing a good job with that work. But we can't necessarily say that because we run a program, for example, in teen pregnancy prevention, that we're going to affect the teen pregnancy rate for our entire state or community, depending on the size of our program. Of course, the larger a program or service population becomes, and as it approaches the full population, then you can start to talk more about population level change. But that's an important distinction to keep in mind whenever you're trying to select how you're going to measure things. So I just thought I would share so in selecting indicators, there's some things that everybody needs to pay attention to, particularly related to things like reliability and validity and what data you're going to choose to track. And some of those are listed in the middle part of this slide. But other criteria that you might use to select your indicators have some values component to them. So at the Children's Trust, when we were going through our strategic plan most recently, we talked about what kind of things we wanted to have in our set of indicators that we would track. We wanted to stay focused on the positive. We wanted to have an acknowledgement of many of the social factors and social determinants that Peter was talking about. So we included family and community related factors as well as direct measures of child well-being. And of course, we're also concerned with children across the age span. So I think that those are things to keep in mind, coming up with your own criteria and then sort of doing a matrix evaluation where you can, take a measure and look at it according to how it fits with your criteria that you're interested in, and then decide, because there's a ton of measures out there that you can pick from. And so then you can kind of help get some guidance on what's going to be the best to track results that you're interested in. Once you go through a process like that, you typically, hopefully, come up with your top choices. We call them at the Trust our headline community indicators, but we don't throw out all the rest. We track a lot of the data still that are relevant to what we do. We also track things that we may not be intending to directly impact, but that we know are important to the things that we are concerned about, like poverty, like housing. So the Trust doesn't fund those things directly, but we know those are important contexts for what we're trying to do. And then we always have our wish list, too, of data that we hope we can develop or that we can create or improve upon to have available. So I think people picked up the handouts. Okay, so you have there was a data snapshot at the sides of each of the tables, and this is just a selection of the ones that are in our strategic plan. And again, just to make the point that the child well-being section at the bottom half of this slide is sort of the core. That's the end that we want to reach. We want children to be, ready when they get to kindergarten, succeed when they're going through school, be physically active and healthy, behave appropriately, and transition successfully to adulthood. But to get there, we have to have the family and community supports that are in the top part of the slide as well. On the data snapshot that I handed out, because we don't really have enough time to go through all of the different indicators that are available, but you can see that each one of these community results can be measured through multiple indicators that we are tracking. And you'll see that there's about 3 pages of data that we track that you can sort of see trends over time. And the third page is actually the social context data that we track. So what are we doing at the Trust is another piece that's in our strategic plan. So our priority investments really focus on prevention services. Many of you are familiar with that. We mostly live in the universal and selective realm. We do have some programs that focus on indicated prevention for families that are having some challenges, but we stay in the prevention world. We also mostly fund direct services, as I said, but because we know that it's really important to also have good public policy, to have public awareness of what's available, to advocate when there's issues that relate to children and families issues. We are involved in many of those activities, as well as collaboration with others in the community to reach our community results, doing our own community research and evaluation, both evaluation of our programs and community research and survey data to assess the needs of children in the community. And we also, as part of that, are embarking in this new funding cycle on doing some innovative funding to look at new ways to think outside of the box to try to make some of the change that we're interested in. So what do we look at when we're looking at a program level performance measure? So Jeff made allusion at the beginning to, counting things. How much did we do? How many services did we deliver? You can also get into the quality world. Obviously, you should be looking at how well you're doing it, and if your customers are happy, if they're coming back, if they're saying that they're feeling accepted and well served. But then, of course, the thing that everyone's interested in is to what end? Did we affect anyone in a positive way and make improvements in their lives? There's really a few ways. I mentioned in the community level, we track the same indicators over time and look at trends. Much similarly, in the program level, you can track your results across time and compare yourself to yourself, just trying to improve as you go. Sometimes you can compare yourself to others, so there may be similar programs and you can use as benchmarks. And then you might be in a field where there are actually sort of standards to be met, and so you can track things according to standards. But it's really important to always remember that the purpose of the measures, and a lot of times in my role at the Trust and research and evaluation, we fund more than 100 agencies. We have almost 200 contracts for different services. We require all of them to have performance measures in them that include all of these things: how much people have done, how well they did it, and whether anyone was better off as a result. But we have to always remember that the purpose for doing that is to get better, to have the services improve, and to reach those important results that we want for children. So just a reminder again, this is a repeat, but to emphasize that program and population measures are both important, but you have to keep them where they belong. So program measures should have a contribution relationship to the population work and moving the needle, but a program alone should not try to carry the weight on the shoulders of their program to make the population level change. That's a setup for disaster. It's also important, though, when you're looking at these, to try to have your measures aligned. So what you're tracking or what's available to be tracked, or you're tracking at the community level, if you can be tracking something very similar for your program, that allows you to sort of see that comparison and when you're tracking your results. So this is just you're not supposed to be able to really read this, but it's just a picture of the top of the first page of the data snapshot. And there's a lot available. We really collect data from a few different sources. A lot of the data that you see on that snapshot is from administrative data that other agencies produce, like the health department, the school system, the Department of Children and Families. But we also do collect primary data. So much of the data that's on the snapshot comes from our household survey of parents. We've done that in 2007 and 2012. We're kind of coming up due to do another administration of that survey. We use national survey questions so that we can have those comparisons that you see on the snapshot. And in as many places as we can, we want to compare Miami-Dade County to the state and to the nation. And then we also collect information in partnership with the school system, and I'm going to tell you about that project in a little bit, with an instrument called the Early Development Index, and looking at kindergartners. And then we track some of the things like quality childcare through our Quality Counts program participants. So the one point, though, is that almost everything on that data snapshot, and this just reemphasizes some of Peter's points, is related to the social context. And in our county, the social context varies significantly by geography. So for a minute, look at this map and try to ignore the bright red lines. And just look at the black and gray squares, because that's poverty. That's the percent of children who are under 18 that live at 100% poverty or less. And so you can see that it's not really spread all throughout our community, and most of you who live here, you probably experience that. You hear in the news how Miami is, one of the poorest places, but maybe everyone in this room doesn't really experience it that way. But certainly people who live in the darker colored areas on the map do. And that's a really important thing to be aware of about our community and about child and family well-being in our community. So back to the red lines for a second, and to something about the Children's Trust in particular. These red lines were drawn with some thought and planning, so they do go along established borders, for different municipalities or zip codes, and for data purposes, we drew the lines to go along some existing divisions that people use. But really, we were looking for a way, after we came out of our strategic plan, to reorganize our work at the Children's Trust and to really try to move from managing our contracts. The way we used to do it was by program type. So all of the parenting programs were managed sort of by one team, all of the after-school programs by another team. But they were sort of spread throughout the county. And just even from a logistical purpose, right, the contract manager has to visit in Homestead and Opelika sites, but more from a theoretical perspective, that we really want programs, the parenting program should know about the after-school program that's right across the street from them. And they should be making referrals to one another. They should be supporting more of this whole child aspect, rather than just, well, all I do is give care after school or maybe help with reading. But you should also be attending to other things. And if you don't do that directly, maybe another program does. And so we really tried to group our contracts into these areas. We have our staff reorganized into these 4 areas. As you can see, some of them are quite large. But we kind of had the resources we had to work with made the division of 4. And I also just like to share quickly, this is what I call our confetti map. So this just shows where all of our services are. So this makes the point that I said earlier, which is we are focused on all children in Miami-Dade County, but with greater emphasis on the more vulnerable children. So we do have a greater concentration of services in, as you can barely see now, the black squares on the map are really saturated with services that we fund. That's not to say that they have enough services. That's not to say that the resources are enough to make to make as much of a difference as we would like, which is why we have to work with others, which is why we're trying to leverage other funders to come and bring more money to Miami and to work with the residents in these communities. So I just wanted to say a couple things about 2 other types of data that I mentioned. So in our household survey, we collect information. We ask the screener questions for children with special health care needs, which is a national survey. So this allows us to get Miami-Dade information and compare it to Florida and the nation. And so there was one slight sampling difference that could be contributing to the different numbers that you see here in this survey, because in our last survey administration, we did not yet have cell phones numbers fully integrated into our sampling frame, and the last national survey did. But we see that the percentages, at least overall, are lower in Miami-Dade. But the other thing we see in our Miami-Dade data is that about 36% of children with special health care needs fall below the 100% poverty threshold. And that compares to 21% overall. So children with special needs are perhaps also affected more by issues like poverty. We ask parents questions about whether they had unmet needs. And so this is I just dug a little bit into the data about, the population that I thought you all might be more interested in. And the services, first of all, like 22% of children with special health care needs parents reported that they needed a service in the past year that they weren't able to get. And that compares to about 17 or 18% of parents that didn't report having a child with special health care needs. Their unmet needs are more likely to be in the areas of mental health, substance abuse, early child care, and academic help outside of school. That's where you see the greater gaps between the bars. So the lighter bar is children with special health care needs. And so about half, when we ask about whether you had difficulty finding care, so maybe you got a service, but was it easy to find? So about half of children with special health care needs report difficulty finding or not finding at all child care or early child care, after school and summer type care. That compares to about a third of parents in general that report difficulty finding that type of care. And about 2/3 of children with special health care needs that have health insurance are on public insurance plans, like Medicaid or Kid Care. So that follows along with the poverty information. So then when we ask parents why they didn't get the service that they needed, what we see is there's differences still between the children with special health care needs and those with not reporting that relate really to children with special health care needs having being more faced with the lack of services, or maybe what we might interpret as poor quality services. They're just not satisfied with what's out there for their child. So the other just quick example of data that we have, or primary data collection effort that we've launched, is we call it TEX EDI because, you know, everybody likes acronyms, everybody in our field. So this is an initiative transforming early childhood community systems that was a Kellogg initiative, started, it's operated out of UCLA. There's sort of 4 strategies to the overall initiative, and the second one really relates to measuring early childhood development. But really, it's not just measures for measure's sake. The whole frame of reference for the TEX project is about community engagement and system improvement. So it's about educating communities about the status of child development in their community, and then mobilizing them to get involved and make change. So the early childhood development instrument is kind of unique because it's not a test that's not like a developmental screener that gives individual feedback. It's collected more at the group level to see how schools or communities are doing. It has 5 developmental domains that you all probably would be familiar with. General areas that are typically measured. Teachers fill this out for their kids, and when do they? It's like February or so of the school year, so they've had some experience with the kids in their class for about half the school year. And we have been collaborating, as I said, with the school district early childhood programs to bring this data in for the past few years. We started small. We had 24 schools in the first year, and then there were 63 schools last year and 61 more schools just this year that ended last year. We don't have our validated data back on those yet, but we're growing the number of kindergartners that we have available, and we'd like to reach all the schools that have kindergarten. The real advantage to this data set is that we have the school address where the child attends. We also have the child's address of residence. So any of you who know about our school system, you know that most kids probably don't go to school right near where they live. So it's important to know both of those. So we can look at the EDI data that we've collected by the address of the children, and this is just showing you our saturation rates. So this is where do we have enough proportion of the 5-year-olds that live in a particular area to be able to say something about that geographic area. And so you can see that over the 3 years, we're kind of progressing along. Our map, the green areas are where we have 75% or higher of children represented. So we can kind of start to talk about what do kids in this part of the smaller local community look like. There's another use of this data is to do maps and analysis where you can not only look by geography to see where different needs might be, but also to correlate with socioeconomic indicators. And you sometimes find patterns that might be unexpected. So this is crossing poverty, which is the red dots. The bigger the red dot, the higher the poverty, with the percentage of children that are off track on the social competence domain. And so you can see it's not a straight line correlation. There's some areas that are dark in color and have a big red dot on them, so that's what we might expect the relationship to be. But then there's some other areas where there's a pretty big red dot, but the shading is a little bit lighter. So kids are not doing as poorly maybe as we might expect. So it helps to tease out some of those more complex relationships. And then what we can do and work with community is really drill down to local level maps and show them. This is an example of Liberty City, a part of the county in the northern corridor. And this is showing where our children are on track in all domains. And then you can also kind of do the flip, so off track in more than one domain. And so the idea is to work with community groups first to really educate about child development, what it means, what does this measure, and how to look at it, but then really to talk about, well, what's happening in a particular part of the community, and what might parents do or residents do to get involved to support child development. So I think Peter was going to come back up for closing.
You can see from those maps, by the way, how easy it is to bring these population data to the residents of a community and arouse and engage them into thinking about, well, how satisfied are we that 29% of our kindergartners, for example, are not developmentally ready to handle the curriculum at school? And if we're less than satisfied, what do we think is responsible for it as parents, as community stakeholders, and what priority should we set for getting to work at making change? And then every 3 years, we reassess with the help of the kindergarten teachers that next cohort, that next wave of kindergarten students, and hopefully each time we assess that, fewer are not prepared developmentally to handle the work that's required of them in school. So it's a wonderful partnership between research and civic action to make change happen that's very meaningful and that requires the collaboration of lots of private and public sector institutions and individuals. We encourage you to work with us, make use of our own data for your own research. Altogether, if zip codes and delayed gratification are going to be not the only way that we need to know how a child is going to do. We're going to need new investigative methods, we're going to need new practice standards, and we're going to need new policies to make those changes. By the way, looking at the maps too of poverty in Miami that Lori showed us, it's well known, well documented that in cities in the United States where poverty is most densely concentrated and where segregation is highest, infant mortality is greatest. So this is going to take a long time. It's going to take a different framework. We're going to have to realize that none of us holds all the keys to solving these major problems, and that we have to work simultaneously at least those 4 essential economic, social, environmental, and educational foundations for children's health and development if we're going to make headway. I put planting date trees there because I once learned that it takes 85 years from when somebody plants a date seed in the ground to when the tree first bears fruit. So nobody plants a date seed for themselves. We have to work at the individual level and at the policy level. My own prescription for taking care of yourself is to be generous, grateful, exercise, take in enough fluids, find happiness but never pursue it, work with purpose, and love with passion. And let's all do our part to lower the social gradient. The marmot councils throughout Northern Europe have been effective within a single generation at leveling the social gradient by doing 3 things: raising the minimum wage, offering health care to everybody, and offering universal, high-quality early education to all children. The social gradient in terms of income, social class, has been leveling consistently over this amount of time. Well-regarded 20th century rabbi and Jewish philosopher noted that few people are guilty, but all of us are responsible. We have to convince the private sector as well as the research community that every decision we make has a potential impact on the health and healthy development of children. Thanks very much.
We have time for one or two questions.
Lori, come on up.
Ask any. So my question would be, have you started taking some of the EDI data to communities, and if so, how are they responding?
Yeah, well, we're in that very first stage, which is stage 2, of taking the EDI data and bringing it to the community for them to decide how to feel about it and how to make use of it. And the very first community that seemed to be ready as a coalition, as a collective, to do that is Liberty City. And so we've had a series of meetings with residents in their homes, in their schools, showing the data and letting them decide how to organize action steps to make change happen, to engage at the same time at the political level of representatives of those communities to teach them, not the residents, to teach the community officers, authority figures, the relationship between community conditions and child outcomes, and how the way you hit kindergarten is pretty much predictive of how you're going to do in life.
So I grew up in Miami, so to me, Liberty City is a very specific place, but your maps are not what I consider Liberty City. They include Brownsville, Alabama. So you're talking about Liberty City.
There's the greater Liberty
Right.
City, and then we've also mapped the smaller, which is more around Liberty Square area. Yes.
And that's really interesting too.
So
We,
that-
yes,
Yes.
Yes,
Yeah, the map
yes.
was the big area.
The 4
And
regions.
In
right.
fact, we have on our website a tool called Kid Stats and Maps, and it actually allows you to draw custom boundaries. Because part of the work that you really find to do when you work with residents is you need to ask them what's their community, and they have to define their own boundaries. And sometimes we do get criticism of the Children's Trust, like we think we're funding XYZ in this area, and they're saying, no, it's 2 blocks that way, so it's not, yeah.
And one of the first and healthiest debates that almost always takes place when we meet with residents is asking them to define the boundaries of their community.
I know this work, wonderful work, you a lot of years, right? I'm very curious to know your tips from your perspective as we are embarking in this reorganization. What makes the best collaborators to engage in this type of work?
Well, the first rule I would say is people who are willing to share credit and responsibility for the data that's produced and the reality that the data represent. We have to get to a point, and this is my great hope with respect to funder collaboratives and research collaboratives in this community that we can model for everywhere, where as a community we pick 4 or 5 headline indicators that we all think matter and are important to work toward, and realize that when we approach or make progress toward those indicators, we all can share the credit for that. When we're slipping, it's all of our concern to do something differently. But we cannot, and this is so hard, especially for nonprofit and even governmental organizations that put dollars into efforts, for a board of directors to not want to know what their return on investment is. we have to start thinking about our collective social return on investment and not worry so much on what we contributed to that. But because we need everybody's input, we hopefully demonstrated that these foundational resources that every child and all children need and that communities require in order to be able to nurture every child in that community are not resourced in any single place. Right?
That's probably a perfect place to end, and I think it wraps together what we're hoping this talk will do, which is, you heard Peter say that we want to make sure that everyone in our community is looking at those same 4 or 5 headline things. And we need to think, as Mailman Center, as Department of Pediatrics, as a university, what is our contribution to this larger effort? And if we're all pulling in the same direction, we're hoping to get better community outcomes. So thank you again, Peter and Lauren, for coming. Thank you.